Neurology quiz number 127. Describe the etiology, pathophysiology, investigation, and management of West Nile virus neuroinvasive disease. Summarize the important features of other mosquito-borne neurological diseases. This is part 1 of 2 dealing with West Nile virus disease. Etiology: West Nile virus is a flavivirus and is composed of single-stranded RNA. West Nile virus is maintained in a cycle between Culex mosquitoes, the primary vectors, and birds, the primary reservoir hosts. Amplification occurs in avian hosts, particularly American crows and house sparrows. Humans and horses are dead-end hosts. They do not develop sufficient viremia to infect feeding mosquitoes and continue transmission. Non-vector transmission routes, while less common, carry clinical significance and include blood transfusion, organ transplantation, transplacental transmission, and occupational/lab exposure. This figure illustrates that birds are the primary reservoirs of West Nile virus, and the virus is transmitted to humans and horses by mosquitoes that have bitten infected birds. Epidemiology: Since 1999, West Nile virus has spread across the continental United States. North America now bears the highest burden of West Nile virus neuroinvasive disease globally. In the US, CDC recorded 56,000 human cases since 1999, of which approximately 25,000 were neuroinvasive. West Nile virus activity is seasonal, peaking in late summer and early autumn, corresponding to peak Culex mosquito activity. Geographic risk in the US is highest in states with warm summers and abundant standing water, such as California, Texas, Colorado, South Dakota, and Illinois. Risk factors for neuroinvasive disease. The most important risk factors determining progression from asymptomatic infection or West Nile fever to neuroinvasive disease include advanced age. This is the most powerful independent predictor, and case fatality rates rise steeply after age 60. Immunosuppression, such as organ transplant recipients, patients on chemotherapy, or prolonged corticosteroids, and HIV infection. Hypertension and cardiovascular disease, diabetes mellitus, and alcohol use disorder. Pathophysiology: Following an infected mosquito bite, West Nile virus replicates in the skin and local lymph nodes. Viral dissemination occurs via hematogenous spread and leads to secondary viremia. Incubation period is 2 to 14 days. CNS invasion: the blood-brain barrier penetration occurs by multiple mechanisms. There can be direct infection of brain microvascular endothelial cells with transcytosis of virions, the Trojan horse mechanism, in which infected circulating monocytes and macrophages migrate across the blood-brain barrier and release virus into the CNS, and retrograde axonal transport from peripheral nerve endings, which occurs in the spinal cord and olfactory pathways. Clinical manifestations: clinical spectrum of West Nile virus features are inversely related to symptom severity. Approximately 80% of the cases are asymptomatic and detected only serologically. Approximately 20% are associated with West Nile fever, which is a mild to moderate febrile illness, and less than 1% get West Nile neuroinvasive disease, such as meningitis, encephalitis, or acute flaccid paralysis. This chart illustrates that the majority of cases are asymptomatic and less than 1% get West Nile virus neuroinvasive disease. West Nile fever: this is a non-neurological illness. There is a 2 to 14-day incubation period followed by fever, headache, fatigue, myalgia, arthralgia, and anorexia. A maculopapular or roseolar rash affecting the trunk, back, and arms and legs occurs in approximately 20 to 50% and may be a useful clue. Lymphadenopathy may be present. The illness is typically self-limited, resolving in 3 to 10 days, though prolonged fatigue and post-infectious symptoms can persist for weeks to months. This figure shows skin rash in a patient with West Nile virus fever. West Nile virus neuroinvasive disease. This comprises 3 principal neurological syndromes which may overlap in the same patient: West Nile meningitis, West Nile encephalitis, and West Nile acute flaccid paralysis/myelitis. West Nile meningitis: the signs symptoms are fever, headache, photophobia, phonophobia, and meningismus. Similar to other causes of aseptic meningitis, CSF analysis shows lymphocytic pleocytosis, normal sugar, and high protein. Prognosis is generally favorable, though prolonged post-infectious symptoms may be noted. Number 2, West Nile encephalitis is the most clinically serious and frequently fatal form of West Nile virus neuroinvasive disease. The hallmark is fever and altered mental status, leading to confusion, delirium, obtundation, and coma. Additional features may include movement disorders such as a tremor, which is a distinctive and frequent feature of West Nile virus encephalitis, seen in 50 to 90% of the encephalitis cases, reflecting predilection for the basal ganglia and substantia nigra. Other features include myoclonus, Parkinsonism, cerebellar signs, brainstem involvement with cranial nerve palsies and respiratory compromise, and seizures which occur in approximately 10 to 25%, and status epilepticus is also reported. Number 3, West Nile acute flaccid paralysis, or AFP, or acute flaccid myelitis, AFM. West Nile virus AFP resembles poliomyelitis and results from destruction of the anterior horn cells in the spinal cord and occasionally the lower brainstem motor nuclei. Some cases with AFP have electrophysiologic features of multifocal motor radiculopathy. This can occur in isolation without encephalitis in a significant proportion, making it a diagnostic pitfall. Key features include acute onset asymmetric flaccid weakness, areflexia in the affected limbs, preserved sensation, bladder and bowel dysfunction, respiratory failure, EMG showing acute axonal motor neuropathy / neuronopathy, and MRI showing T2 hyperintensity in the anterior horn region. Special populations, transplant recipients. West Nile virus is transmissible via solid organ transplantation from infected donors, even those without documented West Nile virus illness. Recipients are profoundly immunosuppressed, resulting in uncontrolled viral replication and frequently fulminant and fatal encephalitis. Any transplant recipient presenting with unexplained encephalitis during the West Nile virus season should be urgently tested, as prompt reduction of immunosuppression in intensive supportive care may be life-saving. Number 2, elderly patients. Age is the most single powerful risk factor for West Nile virus neuroinvasive disease and death. Case fatality rates in patients over 70 years can exceed 20 to 30%. This population warrants aggressive supportive care. Number 3, pregnancy. Maternal West Nile virus infection has been associated with transplantation placental transmission in rare cases. Reported outcomes in infected neonates include chorioretinitis, brain abnormalities, and severe encephalitis. However, the overall risk to the fetus appears low, but adequate counseling and monitoring are appropriate. Investigations, serological testing, IgM antibody detection in the serum or CSF by ELISA is the cornerstone of diagnosis. A positive West Nile virus specific IgM in CSF is considered diagnostic of West Nile virus neuroinvasive disease. IgM is produced intrathecally and does not readily cross the blood-brain barrier, making a positive CSF IgM highly indicative of CNS infection rather than passive transfer from the serum. IgM becomes detectable within 3 to 8 days of illness onset and can persist for months to over a year. West Nile virus IgM in serum. It is sensitive but less specific due to cross-reactivity with related flaviviruses such as dengue, Zika, St. Louis, and Japanese encephalitis. A positive serum IgM in a clinically compatible case provides strong support for the diagnosis. West Nile virus IgG in serum. This develops 7 to 10 days after infection and persists for years, indicating post-exposure rather than acute infection. Plaque reduction neutralization test. This is the gold standard for confirming flavivirus serology and resolving cross-reactive results. It is used in reference labs to distinguish West Nile virus from other flaviviruses. It is time-consuming but highly specific. Number 3, PCR. West Nile virus PCR in serum or CSF has significant limitations. Viremia is typically brief and at low titer, and most patients present after their peak viremia has subsided. Sensitivity of RT-PCR is approximately 50 to 70% in the serum during the acute viremic phase and substantially lower in the CSF. PCR is most useful in immunosuppressed patients and in blood organ donor screening programs. A negative PCR does not exclude West Nile virus. Serology remains the primary tool. CSF analysis typical findings include white cell count of 10 to 200 per cubic millimeter, lymphocytic pleocytosis but may be neutrophilic in the early stages, mild to moderately elevated protein, normal glucose, and serology as discussed above. Neuroimaging, brain MRI is often normal in West Nile virus infection, especially in meningitis. However, diagnostically helpful findings include T2/FLAIR hyperintensities, most commonly in the basal ganglia, especially the globus pallidus and putamen, the thalami, substantia nigra, brainstem and cerebellum. Leptomeningeal enhancement may be seen in meningitis. Spinal cord MRI in acute flaccid paralysis shows T2 hyperintensity in the anterior horn gray matter, also known as the anterior horn sign. The pattern is linear, central gray matter change, predominantly affecting the cervical and lumbar enlargements. DWI restrictions may be seen in areas of acute neuronal injury, especially in the brainstem. This is axial FLAIR MRI showing hyperintensity in the caudate lentiform nuclei and thalami in figure 1, in the substantia nigra in figure 2, and in the pontine tegmentum and dentate nuclei in figure 3. This is sagittal MRI in AFP showing T2 hyperintensity involving the spinal cord, most prominent at C3-C7 in figure 1, T10-11 in figure 2, and near the conus medullaris in figure 3. Electrodiagnostic studies, as indicated earlier, show abnormalities in the motor nerves, which are suggestive of a motor axonopathy/neuronopathy with decreased amplitudes and ongoing denervation, while sensory studies are normal. EEG changes are nonspecific and consist mostly of generalized slowing. However, EEG is often used to detect subclinical seizures in patients with encephalitis. Management, a disease-specific therapy. There is no proven disease-modifying treatment available, and management is supportive. There is no human vaccine available. Supportive neurologic and ICU management. In encephalitis, this includes managing agitation and delirium, airway protection and hemodynamic support, as well as fever control, seizure management when needed. And for acute flaccid paralysis/myelitis, frequent respiratory assessments, early ICU transfer if there is respiratory decline or bulbar weakness, and DVT prophylaxis, etc. Investigation and empirical therapies. Some agents that have been explored include ribavirin, which is limited by toxicity and lack of evidence of benefit in controlled studies. Interferon alpha-2b, used in individual severe cases in small series without definitive benefit established. Intravenous immunoglobulin has inconclusive efficacy. However, IVIG from West Nile virus endemic regions may contain higher antibody titers. And finally, rehabilitation. Early PTOT, mobility and contracture prevention, is important. Address fatigue, cognition, mood, sleep, and chronic pain. Many survivors have persistent deficits, and rehab planning is a core part of neurologic care. Mortality, case fatality rates are approximately 10% overall but vary substantially by syndrome and host factors. Meningitis has the most favorable prognosis with approximately 2 to 3% mortality. Encephalitis has a mortality of approximately 10 to 15% in hospitalized patients, rising steeply with advanced stage, and is 20 to 30% in patients more than 70 years. Acute flaccid paralysis has a mortality of 5 to 10% from respiratory failure. Long-term neurologic sequelae are often substantial, include fatigue and cognitive impairment, motor deficits from acute flaccid paralysis, tremor, depression and anxiety, headache, seizures, and Parkinsonism. Prevention, individual prevention. Currently, there is no vaccine available. Individual prevention relies on reducing mosquito exposure by use of EPA-registered insect repellents, wearing protective clothing, eliminating standing water around the home to reduce mosquito breeding sites, and number B, blood and organ safety. Since the introduction of pt-PCR screening of blood donations of West Nile virus in the US, transfusion-associated transmission has been dramatically reduced. However, it may take 3 days for viremia to be sufficient to cause positive RT-PCR, which is known as the window period. The window period means that some infected organs may be transplanted. Surveillance in transplant recipients during the West Nile virus season is essential.